Hello everyone in CardioMind's channel, and welcome to the 10th video and the last video in the guidelines of acute coronary syndrome, as today we are speaking about the long-term treatment for acute coronary syndrome. The main aim of the long-term treatment is the secondary prevention after acute coronary syndrome in order to increase quality of life for the patient, decrease risk of morbidity and mortality, besides decreasing recurrence rate for acute coronary syndrome. That's why this should start as early as possible after the index event, even before discharge from the hospital. The main reference for this information is not only the guidelines of acute coronary syndrome for 2023, we also depend on the 2019 ESC Guidelines for chronic coronary syndrome and the 2021 guidelines for cardiovascular disease prevention. As we can see in this diagram, the long-term treatment depends on discharge on cardioprotective medications, starting lifestyle management and referring to a cardiac rehabilitation program, and arranging for outpatient department review in order to manage comorbidities and discuss the goals and preference. Then you should support healthy lifestyle choice like smoking cessation, healthy diet, exercise, healthy weight, and psychosocial management. Then continue the optimal pharmacological and cardioprotective medications and try to reach and sustain risk factor treatment targets like the blood pressure target, LDL, and hemoglobin A1c. In our video today, we are going to discuss the cardiac rehabilitation, lifestyle management, pharmacotherapy, imaging, vaccination, and the patient perspectives. Let's start with the cardiac rehabilitation. The recommendation is clear, a class 1 recommendation that all acute coronary syndrome patients should participate in a medically supervised, structured, comprehensive, and multidisciplinary exercise-based cardiac rehabilitation and prevention program. This rehabilitation can be performed in inpatient or outpatient setting, so it can be performed while the patient is still admitted in the hospital, taking age, frailty, the results of prognostic risk stratification, and comorbidities into account. Several studies have found that cardiac rehabilitation after any atherosclerotic cardiovascular disease like acute coronary syndrome or stroke and after revascularization reduce cardiovascular hospitalizations, MI, cardiovascular mortality, and in some studies also it may reduce all-cause mortality. The core components of the cardiac rehabilitations include patient assessment beside management and control of all cardiovascular risk factors, physical activity counseling regarding regular exercise and prescription of exercise training and its level, dietary advice regarding the healthy diet, tobacco counseling that we are going to speak about later, medications counseling, psychosocial management, beside vocational support related to the patient's job. What about the lifestyle management that we are going to speak about with the patient? There is a clear recommendation that all acute coronary syndrome patients should adopt a healthy lifestyle, including stopping all smoking of tobacco, healthy diet, especially the Mediterranean diet, and alcohol restriction. The recent data suggests that alcohol abstainers who stopped alcohol completely had the lowest risk of cardiovascular outcomes, and any amount of alcohol uniformly increases blood pressure and body mass index. That's why a weekly consumption of more than 100 grams of alcohol is associated with decreased life expectancy. So we expect that the recommendation here is to stop alcohol completely like stopping tobacco, but so far the recommendation is just to restrict alcohol to a maximum of 100 grams per week, not to stop alcohol, although any small amount of alcohol relatively increases risk in comparison to alcohol abstainers. Regular aerobic physical activity and resistance exercise are also recommended beside reduced sedentary time. All of this also is helpful to a healthy lifestyle to decrease the risk of cardiovascular outcomes and decreasing cardiovascular morbidity and mortality. And pay attention that daily physical activity does not replace participation in exercise-based cardiac rehabilitation. In this table, we can see the characteristics of a healthy diet, which are nearly the same as the Mediterranean diet. We have spoken about this in detail in the videos of cardiovascular prevention. I am putting the link for these videos in the description below the video. Regarding smokers, we should offer follow-up support, including also nicotine replacement therapy, introducing to them medications that help in cessation like varenicline or bupropion, individually or in combination. Tobacco abstinence is associated with a reduced risk of reinfarction by 30 to 40% and risk of death after acute coronary syndrome by 35 to 45%. Many patients may continue or resume smoking after acute coronary syndrome, especially those with depression or with environmental exposures like their friends or family members are still smoking. And we should advise the patient that he may notice an average weight gain of 5 grams when he quits smoking. But it is important to recognize that the cardiovascular risk from continued smoking is much higher than the cardiovascular risk from gaining weight after smoking cessation. So we should advise the patient regarding the healthy diet to try to minimize weight gain after smoking cessation, but advise him that the weight gain should not stop smoking cessation. What about the e-cigarettes? A common question asked to us by many patients. You can answer your patient that they still contain nicotine, but not as many tobacco chemicals like cigarettes, because here they don't contain the other chemicals like, for example, tar, and they do not use the burning like in ordinary cigarettes. They depend on heating the liquid containing nicotine, so they carry lower risk. However, evidence on their impact on successful smoking cessation as a part of the cessation program is still insufficient, especially whether their using actually helps a person to remain tobacco-free or not, as they still contain tobacco. Therefore, e-cigarettes should be used with caution. As the use of e-cigarettes, the current evidence suggests that they are still harmful to cardiovascular health by increasing arterial stiffness, increasing heart rate and blood pressure, and increasing risk for endothelial dysfunction. So they are less dangerous than ordinary cigarettes, but still carrying a cardiovascular risk. What about the psychosocial issues? There is a twofold risk for anxiety and mood disorders in those with heart disease. Should be cautious about this. And depression and anxiety, psychological stress are associated with worse cardiovascular outcomes and prognosis and increasing risk of non-compliance. So, psychological and pharmacological interventions should be considered for acute coronary syndrome patients with depression, anxiety, and stress. That's why those patients should have their mental well-being assessed using validated tools like questionnaires, for example, before discharge, and consider that if you notice that your patient is on the verge of depression and anxiety, or he cannot deal with stress, you should refer him or her to a psychiatrist in order to deal with these issues, and whether he will use pharmacological interventions or just psychological interventions. What about the sexual activity? Reassure your patients that if they can climb 2 flights of stairs, this is the equivalent to the amount of energy needed during sexual activities. And people who are physically active have less of a risk of adverse events during sexual activity. So there is no reason to prohibit sexual activity for a married couple after acute coronary syndrome. But in male patients with a recent intake of phosphodiesterase inhibitors within 24 hours for sildenafil or vardenafil and 48 hours for tadalafil, you should avoid nitrates. So advise your patient to stop nitrates within this time range for phosphodiesterase inhibitor, and it is better to ask your patient that if he is a regular user of phosphodiesterase inhibitor, try to avoid prescribing nitrates to avoid the risk of profound hypotension if they were used concurrently. Now let's move to the pharmacotherapy for acute coronary syndrome patients. Regarding the lipid-lowering therapy, The clinical trials have consistently demonstrated that lower LDL cholesterol levels after acute coronary syndrome are associated with lower cardiovascular event rates. So the lower the LDL level, the lower the risk for cardiovascular events. You should re-evaluate the lipid profile after 4 to 6 weeks after each new treatment or any dose adjustment to determine whether the treatment goals have been reached or not. And dyslipidemia should be managed with a combination of lifestyle and pharmacotherapy, not only pharmacotherapy, according to the current dyslipidemia guidelines, which is the 2021 ESC Guidelines for Cardiovascular Prevention. The first recommendation is that high-dose statin should be initiated or continued as early as possible, regardless the initial LDL levels, like atorvastatin 40 to 80 mg once per day, or rosuvastatin 20 to 40 mg once per day, preferably before planned PCI, and should be prescribed up to the highest tolerated dose, and it is recommended to achieve an LDL level less than 55 mg and reduce LDL level more than or equal 50% from baseline. Which of them is lower? You should put in your mind to achieve the two goals, and the lower level of them is the target. If LDL level is not achieved despite maximally tolerated statin after 4 to 6 weeks, you should add Ezetimibe. The IMPROVE-IT trial showed that Ezetimibe treatment early after acute coronary syndrome within 10 days was added on top of prior statin therapy or initiated concomitantly in a statin-naive patient, and it was compared with the statin monotherapy. The results that the treatment with Ezetimibe was shown to be safe and providing long-term benefits for cardiovascular outcomes. So if patients are on a maximally tolerated statin dose or having no prior statin treatment with high LDL level indicating that it is unlikely that the target will be reached with a statin monotherapy, you should start Ezetimibe in combination with statin, and this may be considered during the acute coronary syndrome hospitalization. So class 2B to combine high-dose statin with Ezetimibe may be considered during index hospitalization. If still LDL level is not achieved despite maximally tolerated statin therapy and Ezetimibe after 4 to 6 weeks, you should add PCSK9 inhibitors, as the ODYSSEY outcomes trial showed that the treatment with PCSK9 inhibitor Alirocumab was initiated as early as 1 month after acute coronary syndrome, and it was shown to be safe and effective in lowering LDL in those hospitalized with acute coronary syndrome, and the recent data showed improvements in plaque phenotype, plaque regression in acute coronary syndrome patients who are treated with PCSK9 inhibitors. So combined with the data from trials on the long-term benefits of PCSK9 inhibitors and the observational data on the importance of lowering LDL level after acute coronary syndrome, PCSK9 inhibitors should be initiated during acute coronary syndrome hospitalization in those who were not at their LDL goal despite being on statin and Ezetimibe before admission. So you should pay attention to upgrade the lipid-lowering treatment to the highest level according to the level of LDL and what is the target needed to be reached. That's why there is a clear recommendation that you should intensify lipid-lowering therapy during the index acute coronary syndrome hospitalization for those who were in lipid-lowering therapy before admission. So you can start Ezetimibe or PCSK9 inhibitors during hospitalization for those who were on statins. Icosapent ethyl 2 grams twice per day. Sometimes it can be combined with a statin in those with acute coronary syndrome, and triglyceride levels of 135 to 499 despite statin treatment. In some situations, if a patient experienced a second cardiovascular event within 2 years, not necessarily the same type as the first event, for example, he had an MI and within 2 years he had a stroke. In this case, a patient had recurrent atherothrombotic events within 2 years of the first episode. In this case, we can upgrade the statin therapy and the lipid-lowering therapy to reach a lower target, which is less than 40 mg per deciliter. This is a class 2B recommendation. We know that the lower the LDL level, the lower the risk of recurrent cardiovascular events. This is an interesting diagram that shows us how to approach the lipid-lowering therapy in acute coronary syndrome patients during hospitalization and in the outpatient follow-up regarding how to upgrade the therapy. Summarize all the recommendations that we have mentioned shortly. What about beta blockers? There is a clear recommendation that any acute coronary syndrome patient with LV ejection fraction less than or equal 40%, regardless heart failure symptom, class 1 recommendation to start beta blockers. But what about any acute coronary syndrome patient regardless LV ejection fraction? It may be more than 40 or more than 50%, just the class 2A recommendation. Why? Because the evidence for prescribing beta blockers after uncomplicated acute coronary syndrome in those with ejection fraction more than 40% is less well established, and all the large clinical trials testing the benefit of post-MI beta blocker maintenance, except the Capricorn trial, which only recruited patients with ejection fraction less than 40%, were performed in the pre-reperfusion era and mostly enrolling patients with STEMI, not those with non-STEMI. That's why the recommendation for those with ejection fraction more than 40% is lower than those with clear ejection fraction less than or equal 40%. What about RAS blockers? A systematic overview of trials of ACE inhibitors early in STEMI showed that their use is associated with a small but significant reduction in the 30-day mortality, especially in the anterior wall MI. What about the ARNI, the combination of sacubitril and valsartan? ARNI has been shown to be superior to ACE inhibitors in patients with established HFrEF, but the Paradise MI trial showed that patients with recent acute coronary syndrome complicated by heart failure and or LV ejection fraction less than or equal 40%, an ARNI combination was not associated with lower incidence of deaths from cardiovascular causes or incident heart failure in comparison to ramipril. That's why the benefit of ARNI in those with acute coronary syndrome is still questionable. So there is a clear recommendation that ACE inhibitors have a class 1 recommendation in acute coronary syndrome patients with heart failure symptoms, LV ejection fraction less than or equal 40%, diabetes, hypertension, or CKD. While the routine use for ACE inhibitors in all acute coronary syndrome patients, regardless LV ejection fraction, the same rule as beta blockers, just class 2A, and of course, patients who cannot tolerate ACE inhibitors, it is recommended to use angiotensin receptor blocker. The MRA are recommended in acute coronary syndrome patients with an LV ejection fraction less than or equal 40% and heart failure or diabetes. The famous EPHESUS trial showed that Eplerenone was associated with reduced mortality and cardiovascular hospitalization in those with recent MI and LV dysfunction with symptoms of either heart failure or diabetes. Also, the Reminder trial showed a significant reduction in the primary composite endpoint of cardiovascular mortality, rehospitalization or extended hospital stay, sustained VT or VF, ejection fraction less than or equal 40%, or elevated BNP at 1 month in those using early Eplerenone. What about the nitrates and calcium channel blockers? The oral nitrates so far had no survival benefit in MI patient, just used for control of residual angina, so just for symptomatic treatment. Calcium channel blocker also is not associated with any prognostic benefit in a systematic review, including 28 trial, just for blood pressure control and symptomatic benefit. So they can be used in case of residual angina or for blood pressure control as recommended according to the 2021 ACS Guidelines of Cardiovascular Prevention and the 2019 ASC Guidelines for chronic coronary syndrome. What about the sodium glucose co-transporter 2 inhibitor in patients with type 2 diabetes and established atherosclerotic cardiovascular disease? 3 clinical trials demonstrated significant cardiovascular benefits, for example, the EMPERIG outcome trial testing empagliflozin, CANVAS trial testing canagliflozin, and the TIMI 58 trial testing dapagliflozin. In a meta-analysis of the 3 trial, the major adverse cardiac events were reduced by 11% with no clear effect on stroke or MI. This benefit was only seen in those with established atherosclerotic cardiovascular disease, and so the benefits of SGLT2 inhibitors may relate more to cardiorenal hemodynamic effects than to atherosclerosis. The EMI trial testing empagliflozin, it showed that it led to significant improvement in NT-proBNP reduction over 26 weeks post-MI, accompanied by a significant improvement in the echocardiographic, functional, and structural parameters, and the ongoing outcome trials in acute coronary syndrome patients will be useful in order to define the role of SGLT2 inhibitors in absence of heart failure. Regarding the PPI, which are commonly used routinely in acute coronary syndrome patients, this is a malpractice because PPI should be combined with DAPT in case of patients at high risk of GI bleeding, for example, history of gastrointestinal ulcer or hemorrhage, use of anticoagulant therapy like in case of triple antithrombotic or dual antithrombotic, chronic non-steroidal anti-inflammatory drug use or chronic steroid use, 2 or more of the following factors like age more than or equal 65 years, dyspepsia, GERD, H. pylori infection, chronic alcohol use. In this case, you should use PPI, otherwise don't add them. There is a famous theory that some PPI like omeprazole and esomeprazole may inhibit the cytochrome enzyme responsible for activation of the prodrug of the clopidogrel into the active form, so they may reduce the pharmacodynamic response. However, there is no strong evidence so far that this may result in an increased risk of ischemic events or stent thrombosis in clinical trials. So it is a famous theory, and some doctors may avoid omeprazole or esomeprazole with clopidogrel, but so far there is no strong evidence for this practice. However, there is no interaction between PPI and aspirin, prasugrel, or ticagrelor, so all PPI can be used safely with these antiplatelets. There are 2 terminologies that we should be aware of, which are adherence and persistence. Adherence is the extent to which a patient adheres to a prescribed treatment or a lifestyle advice, while persistence is the length of the time between initiation and discontinuation of a prescribed treatment or a lifestyle advice. And promotion of adherence and persistence are essential to prevent recurrent cardiovascular events after acute coronary syndrome. There are some contributors to suboptimal adherence and persistence. For example, polypharmacy. The higher the number of pills, the higher the risk of suboptimal compliance. Drug regimen complexity. For example, some medications are taken twice or 3 times per day. Regarding the duration between the 2 doses, like for example in oral nitrates, some medications to be taken on empty stomach or after meals, the complexity of the regimen may increase the risk of non-compliance. Poor doctor-patient relationship. A doctor is just giving instructions to the patient without explaining to the patient the nature of his disease and not giving the patient a way to communicate with him easily in case of side effects or in case of trying to find an alternative for one of the medications. This increases the risk of poor compliance. Lack of patient-centered care and disease acceptance. You didn't pay much time in order to make your patient the center of your care and try to convince the patient to accept the chronicity of his disease in order to take long-term treatment. Concern regarding some side effects. For example, a famous side effect for beta blockers, which is erectile dysfunction in males. If you didn't communicate with your patient regarding side effects, he will stop the beta blockers directly without telling you. And cognitive and mental ability may impair the adherence and persistence. Financial aspects regarding the cost of medications, because you should pay attention to these issues in order to try to provide the medications to the patient in the lowest cost, for example by donations or some organizations that may provide the medications to the cardiac patients. Patients who are living alone are at higher risk of suboptimal adherence and persistence, and of course, depression reduces the adherence and persistence to the medications and lifestyle modification. One of the recommendations to improve adherence and persistence are the polypill combination, as they increase adherence in post-acute coronary syndrome patients and so improve the therapeutic targets. The SECURE study, it is the only randomized controlled trial that tested the impact of a strategy based on a polypill containing aspirin, ramipril, and atorvastatin versus the usual care on the hard outcomes in acute coronary syndrome patients, and it showed a significant reduction in major cardiovascular events driven by a significant 33% reduction in cardiovascular mortality. Mobile phone applications and health tools may also improve the medication adherence, but so far there is no strong evidence as clinical trials of sufficient size and duration are needed. So there is a clear Class 2A recommendation to use a polypill as an option to improve adherence and outcomes in secondary prevention after acute coronary syndrome. What about the anti-inflammatory drugs? We know that there is an inflammatory mechanisms for the atherosclerosis and for the cardiovascular events. So low-dose colchicine 0.5 mg just once per day may be considered as a Class 2B if other risk factors are insufficiently controlled or the patient is still having recurrent cardiovascular events under optimal therapy. The COLCOT trial, which enrolled more than 4,000 patients with recent acute coronary syndrome, it showed that low-dose colchicine was associated with a significant reduction of the primary composite endpoints in comparison to placebo, but pneumonia was more frequent in the colchicine group that may be due to an immunosuppressive effect. Also, the low-dose colchicine trial too, it enrolled more than 5,000 patients with chronic coronary syndrome randomized to colchicine versus placebo, and it showed significant reduction in the primary endpoint, but the incidence of non-cardiovascular deaths was higher in the colchicine group. This explains why the recommendation for the colchicine is still Class 2B. Now let's move to the imaging in the long-term treatment for acute coronary syndrome. The recommendation is that patients with a pre-discharge LV ejection fraction less than or equal 40% should have a repeat evaluation for the ejection fraction after 6 to 12 weeks. So we speak about maximum 3 months after an acute coronary syndrome and complete revascularization and starting optimal medical therapy. This is essential to assess the potential need for sudden cardiac death primary prevention ICD implantation. Sometimes cardiac magnetic resonance should be considered as an adjunctive imaging modality if the echo is not sufficient to assess the LV ejection fraction. Don't forget the vaccination for those patients, as the annual influenza vaccine is recommended for all acute coronary syndrome because it is associated with a reduction in the incidence of MI, improved prognosis in those with heart failure, decreased cardiovascular risk in those more than 65 years, and lower risk of all-cause mortality and cardiovascular deaths at 12 months. Therefore, the annual influenza vaccine is recommended for all acute coronary syndrome patients, preferably during the index hospitalization and during the influenza season for those not protected by the seasonal vaccination. And don't forget the vaccination against COVID-19 still recommended, but there is no clear recommendation to use it. And the last point to speak about today is the patient perspectives, meaning the point of views or the opinion of the patient regarding their disease and the treatment plan. The notion of a patient-centered care is recommended in order to assess the individual patient preference, needs, and beliefs and try to adhere to them, and ensuring that the patient values are used to inform all clinical decisions, and it is recommended to include acute coronary syndrome patients in decision making in order to inform them about the risk of adverse events, radiation exposure from cardiac catheterization, and alternative options if they refused cardiac catheterization. Decision aids can be used in order to facilitate the discussion. It is recommended also to assess symptoms using methods that help the patient to describe their experience. For example, giving them a scale from 1 to 10 to describe the severity of their pain. Try to determine the nature of their symptoms, whether they are feeling pain or shortness of breath, and try to give them some examples, and sometimes comparing current symptoms to their previous symptoms during acute coronary syndrome. There is a famous technique which is called the teach-back technique, in which you explain a new concept, for example, a procedure, to the patient, then you ask the patient to explain this concept back to you, and then try to review the points missed or incorrectly interpreted by the patients, then ask the patient again to explain this concept to you. This is a famous technique that can be used during the informed consent for cardiac catheterization. So there is a class 2B to use the teach-back technique for decision support during an informed consent for cardiac catheterization. For example, patient discharge information should be provided in both written and verbal form before discharge, with adequate preparation and education for the patient discharge using the teach-back technique, sometimes motivational interviewing and giving information in chunks, and check whether your patient understood this information or not. And don't forget to assess the mental well-being using a validated tool with inward psychological referral when appropriate, according to the mental status of the patient. This is an interesting diagram that you can give to your patient regarding how he improved the heart health after acute coronary syndrome. For example, smoking cessation, the healthy diet, avoiding alcohol, regular exercise, regular follow-up with the doctor, taking the medications, the flu vaccine, knowing the target for the LDL, body mass index and blood pressure, and how to manage his or her stress. And another diagram that shows the patient concerns and the patient educational needs pre-hospital, in hospital, and then after discharge. So we have reached the end of our video today and the end of the guidelines of acute coronary syndrome. Our take-home message is that treatment of acute coronary syndrome is not only during hospitalization. You need to focus on the long-term plan after discharge in order to reduce recurrent acute coronary syndrome, preserve the LV function as much as we can, and improve quality of life. Besides the long-term aim to reduce cardiovascular mortality. So treatment of acute coronary syndrome is not just cardiac catheterization and giving the patient some medication. You need to focus on the long-term plan in order to reduce the possibility that this patient may come to you again with another acute coronary syndrome. Thank you very much for watching the last video in the guidelines of acute coronary syndrome, and we are starting soon a new guidelines, which would be the guidelines of cardiomyopathies.